organization. And with the advanced modality of diagnosis, now it's possible to diagnose the keratoconus at very early stage. Previously, most of these cases were diagnosed as a case of meridional amblyopia. Therefore, with the availability of the recent imaging technology, it is possible to diagnose these cases at early stage. Usually, keratoconus presents at the early stage puberty and progressive till third or fourth decade of life. And one of the most common association of the keratoconus is atopy and eye rubbing. Many patients have a habit of sleeping with pillow stuck to their eye or constantly rubbing their eyes with the knuckle, and this can lead to repeated microtrauma of the cornea, leading to keratoconus. Once we were pursuing residency, it's very common to ask various signs of the keratoconus, which includes the Vox stria, the Fleischer's ring, the enlarged corneal nerves, Munson sign, rigidity sign, Schauer's oil droplets sign on the retinoscopy, and the sealing of the retinal reflexes. These signs are very commonly seen, but one of the most important diagnostic modality is the corneal topography. And if you do the histology of the, and Dr. Dharm Veer Singh very nicely, very elegantly discussed the use of the, this membrane is one of the very important membrane, and which Dr. Dharm Veer showed through his various innovation how you can use basement membrane to for various cases, difficult cases, to manage the perforated corneal ulcer where this basement membrane can be used. And one of the important innovation can be used in keratoconus field also, which is one of the topics nowadays. The question comes, why there is a renewed interest in the keratoconus? The first, because the refractive surgery in India is taking very scaling up, and with the availability of the newer diagnostic and treatment modalities, now more and more cases are being improved corneal topography system, which can pick up the regular and irregular astigmatism very quickly, and it is possible to diagnose the keratoconus in early stage, what is known as keratoconus form 4C. The most important sign of the keratoconus is asymmetrical bow tie with skewing of the axis seen in the topography. This is the confirmation of the keratoconus, and it's very important that any anterior layer, posterior layer, so that we cannot miss the keratoconus pattern, or we can see any red flag sign also very nicely with this system. So coming to what are the errors in diagnosis, PMD and Terrian's marginal degeneration, and the management of the keratoconus can be done. It depends on the stage of the keratoconus. You can use glasses, prescribed glasses, but in advanced stage, it is not possible to correct the vision with the glasses. So in those cases, it is important to use contact lenses, toric, RGP, hybrid, Roche K, scleral, mini scleral, contact lenses, etc. The commonest treatment for keratoconus management is riboflavin assisted collagen cross-linking, C3R. This is one of the most commonly used treatment modality for the progression of the keratoconus in cases of progression there, and in order to retard the progression of the keratoconus. In advanced stage, you can use the lamellar and full thickness corneal surgery, and of course, if there is a associated cataract is there and keratoconus is stable, you can use toric lenses. And for stable keratoconus with high refractive error, where Lasik, in most of the cases, Lasik laser refractive surgery is not possible because of this is contraindicated. In those cases, phakic lens can remain. Most of the cases can be managed at early stage. Contact lenses are available to manage keratoconus, but in India, most of these lenses are very less commonly used because of their cost and other factors. The most important tool or technique to manage the keratoconus is the collagen cross-linking. This is an excellent research technology developed by Professor Theo Seeler and Dr. Sport, and this has changed the total management of the keratoconus. Collagen cross-linking is very important tool to retard the progression of the keratoconus, and most of us are following the REST protocol. And with the availability of the accelerated corneal cross-linking, Now it is possible to finish the cross-linking in 10 minutes time. As you see from this diagram, the cross-linking can be helpful to strengthen treatment, and always before taking any case, it's very important to document the keratoconus by doing the topography, by taking the corneal thickness, and we always do the corneal cross-linking after putting the polycarbonate eye drop to minimize the damage to the crystalline lens. And you can use 20% alcohol for 20 seconds to debride the corneal epithelium, or this can be debride without alcohol also. And after debridement of the corneal epithelium, you can use the riboflavin drops. And with the availability of the accelerated corneal cross-linking technique, now it is possible to finish this technique in topography. You can use the cross-linking, and it's very important to do the corneal thickness. If corneal thickness is say 400 bonus, and I'll be showing just very brief two videos. This is a video showing the keratoconus management with the toric lens. So toric lens can be one of the important modality to manage the keratoconus, especially stable keratoconus. So this patient came to us and there was no progression of the keratoconus, so we used the toric phakic lens, and the toric phakic lens can be used to correct the refractive error in these cases. So the technique is very simple. You can just mark the cornea and then make incision, use SPMC and inject the toric phakic lens into the anterior chamber. And this is the toric phakic lens made from one of the Indian manufacturer, and then you can tuck the 4 haptics behind the iris and use the polycarbonate eye drops to constrict the pupil. Remove the viscoelastic carefully without any trauma to the lens, and you can see the post of excellent visual correction after toric phakic lens implantation in this case of keratoconus. This is a brief video showing management of cataract with the keratoconus. This case was case of cataract, and we have used the Ultima Smart toric lens with 10 diopter cylinder and plus 4 diopter was power. The surgery was done, and this was followed by the implantation of customized smart toric intraocular lens in case of stable keratoconus. So these are the various tools and technologies are available to manage keratoconus cases and to give them good vision. And it's very important to do periodical follow-up of these cases to just see how the refractive outcome is progressing. And this is the last case of management of the acute hydrops. Acute hydrops is one of the emergency in case of keratoconus. This video courtesy of American Academy of Ophthalmology, and this shows very nice use of SF6 injection to manage the acute hydrop. As we all know that acute hydrops occurs when there is a rupture of desperate membrane and aqueous hydrate the stroma. So this is PI is being done, and then you inject the SF6 gas, and you fill the anterior chamber 60%, and then because of expansile nature of the SF6, this compress the desperate membrane, and then you can see the clear cornea. So this is a very elegant way of managing acute hydrops. So now there are various recent advances are going on, as very nicely pointed out by Dr. Dharm Veer in his talk. One of the recent advances is corneal allogenic intrastromal ring segment, what is known as KDOS by the Dr. Sujan Jacob, and there is a use of these segments as well as lenticular intrastromal keratoplasty. These are the new modalities to manage keratoconus. A lot of research is going on, and soon we will be having these techniques to use in our clinical setup. So these are some of the videos which I have taken from net to show you, to share with you some of the recent advances in the management of keratoconus. So to summarize, it's very important to, once you see any case of keratoconus, you can use some of these algorithms which are shown here. You can see these are some of management guidelines for keratoconus, and the take-home message is that any patient comes to us in the OPD with high cylinder, not correcting to 6x6, always take care reading and do topography. Always document these cases. If there is a documentation, if there is a progression, then always go for CPR. Then regular follow-up is very important. Thank you very much.
Thank you, sir, for your presentation. I hope it would be very helpful